Hello and welcome to my channel. Today we want to look at analgesics. We want to look at the classes of analgesics, and we want to exploit how they work, examples of these analgesics, and basically look at the two types of analgesics. So let's zoom in. So when we talk about analgesic, the term simply means pain reliever or a painkiller. So analgesics are basically agents or drugs that are used for the purpose of achieving analgesia, which means they are used to diminish the sensation of pain. Note that we highlight the word diminish because analgesics do not take away the pain completely, but they diminish the sensation of pain. Sometimes the diminishing intent can be so well that you may not even feel any pain at all. There are two ways by which these analgesics work, and these two ways gives us the two types of analgesics that we have. They work either by reducing inflammation at the site where the pain is, or they work by changing the brain's perception of the pain. Now, this gives us the two ways by which the analgesics work, and it also gives us the two main ways of classifying analgesics. Now, when we say pain, according to the International Association for the Study of Pain, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Now, here is a very important point to note that pain, because it point is associated with an actual or potential tissue damage, the presence of pain tells you that the body may be experiencing a tissue damage. So the first thing to do is not to go in for analgesics immediately, but you may also want to find out what is the underlying reason for the actual tissue damage or the potential tissue damage. But once you've been able to identify this underlying reason, then you can now attack the pain from the root rather than just the symptom of pain. Pain can be sensory, pain can be emotional. And most of the drugs we're going to discuss mostly deal with sensory pain. Now, there's another class of drugs that can cause you to lose sensation, and in losing sensation includes the sensation of pain. So in this instance, these other class of drugs known as anesthetics can behave like painkillers because they cause you to lose sensation of pain. However, anesthetic agent can also cause loss of awareness or consciousness, which analgesics do not cause. In other words, analgesics will diminish the sensation of pain, but anesthetics will numb or cause a temporal loss of the sensation of pain. Good. Now, let's classify our analgesic. We'll put them into three main classes, and basically it's two, and the third one being a combination or a compound of the first two. So the first class of analgesics is known as the simple analgesics. It's also referred to as the non-opioid analgesics, and also be referred to as the non-narcotic analgesics. So sometimes we call them simple non-opioid analgesics or non-narcotic analgesics. The second group is the opioid analgesics or the narcotic analgesics. And the third class is a combination of a simple and an opioid, making it a compound analgesic. A compound analgesic, therefore, must include a simple analgesic and an opioid analgesic. If you combine two or more simple analgesics, it still remains a simple analgesic. If you combine two or more opioid, it still remains an opioid. And when you combine a simple analgesic and an opioid, then it becomes a compound analgesic. So what are some examples of our simple non-opioid analgesics? Basically, when we talk about simple non-opioid analgesics, we look at two main types of drugs or drug classes. These include paracetamol and non-steroidal anti-inflammatory drugs, also known as NSAIDs. Now, paracetamol is technically not added to NSAIDs simply because paracetamol does not have the ability to cause or to reduce inflammation, whereas NSAIDs reduce inflammation. Now, this type of NSAIDs, note, are referred to as non-steroidal because structurally, they do not have a steroid in their chemical structure. So paracetamol, even though may have analgesic property, may have antipyretic property, does not have anti-inflammatory property. NSAIDs, on the other hand, has analgesic property, anti-inflammatory property, and antipyretic property. So it is the inflammation part that distinguishes the anti-inflammatory property that distinguishes paracetamol from other NSAIDs. These, we say, work basically through reducing local inflammation response. So examples of these NSAIDs includes salicylic acid or salicylate aspirin, Sulindac aspirin-like drugs, diclofenac, ibuprofen, naproxen, mefenamic acid, indomethacin, etc., etc. Now, these are all NSAIDs. In fact, NSAIDs become one of the most common types of pain relievers we have. They are used mostly for mild to moderate type of pain. They are almost always over the counter and available for over-the-counter purchase. Now, the second class of drugs or analgesics are the opioids. Now, these ones are not over-the-counter. These ones are prescription-only medications, and they are described as the strongest of analgesics. These are used for severe pain, and they can be used for long-term or short-term pain. Now, how do these class of drugs also work? They affect or reduce pain simply by changing the brain's perception of the pain. Basically, put another way, they block pain signals from reaching the brain. So the brain does not notice that there is pain. And in this way, the person or the patient is comfortable without feeling the pain, or will have a diminishing of the pain sensation. Examples of these drugs include morphine, codeine, pethidine, fentanyl, tramadol, hydrocodone, oxycodone, etc., etc. Now, when you combine a simple analgesic and an opioid analgesic, you get a third class of analgesics known as a compound analgesic. So note that a compound analgesic must contain a non-opioid or a simple analgesic, and it must contain an opioid, usually a low-dose opioid. So examples include paracetamol with tramadol, or paracetamol with codeine, or paracetamol with dihydrocodeine, or aspirin, paracetamol, and codeine. So the combination, when there is a simple opioid and a simple analgesic and an opioid, you get a compound analgesic. We could also combine simple analgesics, and we can combine opioids without combining one class with another class. In this case, a combination of one or more simple analgesics will be referred to as a simple analgesic combination. Now, some of these combinations are also available on the market, and you can purchase them. Now, these ones are available sometimes with or without an adjuvant. An adjuvant in this instance means an agent that is going to increase or enhance the analgesic effect that our painkillers are to give. And various agents have been used. Those that will induce sleep, for example, diphenhydramine. Those that can enhance the analgesic effect, like caffeine. So depending on what your desired effect is, you may use one or more adjuvants. So if you have a combination aspirin, paracetamol, if it is codeine, it becomes a compound analgesic. But if it is caffeine, where caffeine is the adjuvant, that will be called a simple analgesic combination. So you can have brufen, paracetamol with or without the caffeine, aspirin, paracetamol with or without the caffeine. And that becomes simple analgesic combinations. Simple analgesic combinations. Now, here are some common properties that we want to use to distinguish between these two main classes of painkillers. So the first, like we've been talking about, is opioids. Now, note we said opioids are also called narcotics. The idea of narcotic means that they can induce sleep. So opioids do induce sleep, whereas NSAIDs do not induce sleep. Again, we said narcotics or opioids change the brain's perception of pain. So opioids act centrally through the brain or on the brain, whereas NSAIDs act peripherally. Because opioids are working through the brain or on the brain, they can cause addiction. So opioids can lead to addictions, whereas NSAIDs do not cause addictions. Because they are still working on the brain, we can also see that these opioids can depress the brain, so they can cause CNS depression, whereas NSAIDs do not cause CNS depression. NSAIDs, on the other hand, irritates the gastric mucosa, and this can actually lead to gastritis, or it can lead to ulcers. So NSAIDs are known to cause gastritis or ulcers. In fact, this is why mostly we advise our patients to eat before they take NSAIDs. Opioids, on the other hand, do not produce gastric irritation. NSAIDs, one of their cardinal properties, we said, are anti-inflammatory. They have anti-inflammatory effect. Opioids do not have any anti-inflammatory effect. And we use opioids for long-term or short-term pain, and they are used for severe pain, whereas NSAIDs are used for short-term pain relief, and they are used for modest pain. Now, so how do we use these pain medications for these types of pain? In this term, we are looking at moderate pain, modest pain, severe pain. So according to the World Health Organization, this is what is known as the WHO pain ladder. So according to the WHO, depending on the intensity of the pain, we could start pain management with a simple analgesic, a non-opioid, whether it has an adjuvant or not. That is where you start from, step one. But if the pain is not responding or the pain gets worse, then you jump to step two, where you add a weak opioid to your simple analgesic, or you use a weak opioid without the simple analgesic. You can also add an adjuvant, or you can subtract the adjuvant. If the pain still persists and is worse, you go to step three. In step three, you are using a strong opioid with or without a simple analgesic and or adjuvant. So you can skip the adjuvant, you can skip the non-opioid and use strong opioids if that is going to give you the relief. But it's almost always better to use the combination. In other words, it's better to use the compound type of analgesics. And there are two main reasons why we prefer compound to the individual agent. One, when you make a compound, you can reduce the strength or the dose of the individual ingredient, thus reducing the side effect associated with the individual agent. So, for example, we talked about paracetamol combination with tramadol. Example of the brand on the market is Doretta. Normally, if we are giving paracetamol to an adult, we could go up 1 gram, sometimes even more. But whilst we're using paracetamol in Doretta, the strength is basically 320 something, 25. Now that is way low if you compare it to 1 gram. And then tramadol, we use 50 milligram or 100 milligram, but in Doretta, it is about 37. So that means that it has reduced the dose, and therefore the associated side effect will also be reduced. If after you've gone through step one, step two, step three, your patient's pain has been resolved, you can move down depending on how well your patient does. But if the pain is still persisting, then you do what is known as an interventional treatment. And in the case of interventional treatment, it means you are adding the interventional treatment to the steps that you have taken in step three. Interventional treatment means you are going to be doing either you're going to use a local anesthetic agent. In other words, you're going to do a nerve block, or you are going to do a neurolytic block by using an analgesic, an anesthesia to block a nerve that leads to where the pain is coming from. You can do a epidural analgesia, spinal analgesia. All of these are means by which you are trying to reduce the pain. Now, these are interventional treatment. Remember, we said that analgesics do cause the loss of sensation. And so you can do that intervention, which is step four. We have gone beyond painkillers to do an intervention if the pain is very severe and is not responding to the conventional management or treatment. Now let's look at quickly the mechanism by which these two drugs work, or two classes of drugs work. Let's first look at the NSAIDs. The NSAIDs, the non-steroidal anti-inflammatory agent. So now in this picture, we see here our cell membrane in the skin or whichever part of the body the injury may occur. Now, assuming that this skin or cell membrane is exposed to something that stimulates inflammation, it could be bacterial infection, it could be an injury. If, for example, let's use an injury as our case study. If an injury occurs in the cell membrane, there is the release of what is known as arachidonic acid, which is found in the phospholipid membrane, which is our cell membrane. Now, the release of arachidonic acid, which is here portrayed as AA, is the initiation of the inflammatory process. Because once arachidonic acid has been released, the enzyme cyclooxygenase, which is here portrayed as COX, is going to act on arachidonic acid to release prostaglandins. Prostaglandins are the mediators of pain and inflammation. So the release of prostaglandins is what leads to the inflammation and the pain. Now, how do our NSAIDs work? Basically, our NSAIDs work by inhibiting the activity of the COX enzyme, the cyclooxygenase enzyme. That means after the injury or the infection or whatever is stimulating the inflammatory, there may be the release of arachidonic acid, but because we are inhibiting the cyclooxygenase, arachidonic acid is not converted to prostaglandin. And once it's not converted to prostaglandins, then it will not lead to its mediation of pain and inflammation. And this way, it helps to diminish the sensation of pain. Note that there are two types of COX, COX-1 and COX-2. And it's been shown that COX-2 actually are the ones that are involved in the mediation of inflammation and pain. Therefore, a group of scientists also brought up the COX-2 selective NSAIDs, which means these were designed to selectively inhibit COX-2 and leave COX-1 uninhibited. This has its advantage because the inhibition of COX-1 results in the gastric mucosa protection being lost, and that is what makes NSAID irritate the gastric mucosa and could lead to ulceration or could lead to gastritis and ulcers. Now, the introduction of COX-2 selective NSAID, also known as COSIFs, actually helped reduce the ulcers and the gastritis that were associated with the use of NSAID. They came with their own problems, but at least the aim of trying to overcome the problem of gastric issues was achieved with COX-2 selective NSAIDs, also referred to as COSIFs. Now, this is a side note that I want to bring your mind to. Remember, we said NSAIDs are non-steroidal anti-inflammatory drugs. Steroidal anti-inflammatory drugs, also called corticosteroids, also work through this same pathway. However, they inhibit a different enzyme, phospholipase A2, which is actually the enzyme responsible for the release of the arachidonic acid from the phospholipid cell membrane. So corticosteroids actually inhibit phospholipase A2 and prevent the release of arachidonic acid. And this is how they too are able to achieve their anti-inflammatory activity. All right. So this is what we've been saying, that when it comes to NSAIDs, they work simply by inhibiting the synthesis and release of prostaglandins from arachidonic acid by the activity of the enzyme cyclooxygenase. Then we are saying that note that prostaglandins actually are the inducers they induce the responses in tissues, local tissues, which includes pain and inflammation, which is what we are looking at. They can also, prostaglandins are responsible for blood clotting activity, and they are also responsible for induction of labor. Now, these two become side effects that our NSAIDs can give us. For example, NSAIDs are known to cause bleeding, especially the aspirin group. Why? Because they are inhibiting the prostaglandin formation, and hence the activity done by prostaglandin, which is the formation of blood clot, is lost. So actually, NSAIDs can cause bleeding. All right. Then NSAIDs can induce labor or terminate labor. Prostaglandins help in the induction of labor, but if prostaglandins are being prevented from being formed, if the formation of prostaglandins are stopped, then the induction of labor can also be affected. Good. So we talked about COX-1, COX-2, and we've seen that COX-1 is found in most normal tissues, whereas COX-2 are actually the ones responsible for the inflammation processes. So they are induced in the presence of inflammation. And this is why the COX-2 selective drugs, the COSIFs, were formed. And their formation brought the benefit of less gastric ulceration and irritative effects. All right. Now, here are some other benefits of prostaglandins. Prostaglandins help with clotting. We've mentioned that. They help protect the gastric mucosa. Prostaglandins are also good in resistance of thromboembolism formation. Prostaglandins are good in inflammatory, or they are effective for inflammatory, or they are inducers of inflammatory, and they can also act as anti-inflammatory. There are basically 5 types of prostaglandins, but we will not go into that because that is out of the scope of our study today. Now, how do our opioids also work? Opioids are believed to work through nerves or neurons. And basically, because we said they interrupt the transmission of pain, basically the activity has something to do with the transmitters of pain, which in this case becomes pain neurotransmitters. So if you take our opioids, this is the presynaptic neuron, this is a postsynaptic neuron. In between a presynaptic neuron and a postsynaptic neuron, there is a gap. Now, it is through this gap that communication is made from one neuron to another. And depending on the neurotransmitter that is used, then the intended communication is made. Now, in this picture, these red spots here are representing pain neurotransmitters. Now, we are saying that when we take our opioids, they actually work on activating opioid receptors, which can be found on both the presynaptic and the postsynaptic. So the receptors are found on both neurons, presynaptic neuron, postsynaptic neuron. Now, the activation of the presynaptic opioid receptor leads to the inhibition of the release of these pain neurotransmitters. And once the neurotransmitters of pain are not being released, then the pain communication or information is not being transmitted. The activation of the postsynaptic neuron, on the other hand, also inhibit the action of the neurotransmitter at the postsynaptic neuron. So basically what it means is that when we talk about our opioids, they work on both presynaptic and postsynaptic. At the presynaptic level, causing or inhibiting the release of neurotransmitters. At the postsynaptic level, they also inhibit the action of the neurotransmitter. So that means opioid works at both the presynaptic and the postsynaptic. They activate opioid receptors at both the presynaptic and the postsynaptic. It has been shown that the activity at the presynaptic, which is the inhibition of the release of the neurotransmitters, is actually considered the major effect, whereas the activity at the postsynaptic is the minor effect, the minor effect. There are other agents that we could use for some specific pains, like if we consider migraine headaches. Here are a group of drugs that we can use to help with migraine headaches. So the triptans, fluvotriptan, sumatriptan have been used to help with migraine headaches. Beta blockers can also help one way or the other with the symptoms of migraine headaches. Anticoagulants have been used to help. Antidepressants, calcium channel blockers, specifically nimodipine, the ergot alkaloids, ergotamine dihydroergotamine, methotrexate, clonidine, and pizotifin have all been used. Now, you see, these are various agents belonging to different classes of drugs, but they can all help to either prevent a migraine headache or relieve migraine headaches. So primarily, they are not used as such, but their effect can be very helpful in migraine headaches. And of course, NSAIDs that we've been discussing can also help with migraine headaches. Now, how safe are our analgesics? Are they safe to be used? Well, most analgesics are considered safe. Most of them are considered safe. However, some are considered more safer than others. Now, we say considered safe if you are using it within the usually the prescribed short period of time. Most of the time, we use this agent for short periods of time. Their side effects we can pronounce or kick in when you're going to use them for long-term effect. So if you're going to use them as prescribed, usually they are considered safe. Among the NSAIDs, ibuprofen and paracetamol are considered more safe than the others. Ibuprofen is considered so safe that you can even give it to children from 3 months upwards. It's the only NSAID that has been cleared to be used in children 3 months upwards. Then paracetamol or acetaminophen is also considered a safe analgesic, which can even be used from birth, even though nobody encourages that. If there's the need, it will be used, but nobody likes to give medicine. All right. Now, even though we consider these agents as safe, if we take our NSAIDs, they've been shown to cause an increase in the risk of heart attacks, fatal heart attacks, and strokes. Now, this covers both the general NSAIDs, specifically, for example, diclofenac, and even the corticosteroids, celecoxib. They've all been shown to increase the risk of heart attacks and strokes. Now, because of that, we advise that NSAIDs should never be used before surgery, just before surgery or after surgery, and especially a heart bypass surgery. This is very important because of its effect on the heart. So we don't want NSAIDs to be used before or after, immediately before or after a bypass surgery, a heart bypass surgery. Also, because of the increased risk of gastric irritation and which can lead to gastritis or ulcers, NSAIDs are known to cause these ulcers or gastritis. And this is why we advise our patients to eat before they take the medication, just to help protect the mucosal wall a bit. Other side effects that have been shown will include bloating, diarrhea, constipation. These are GI side effects that sometimes you experience with the use of your NSAIDs. And we also mentioned the fact that NSAID could also precipitate or cause increased bleeding, especially aspirin. So that is also something we should note. Then we're saying that with the exception of ibuprofen, which has been cleared for use in children 3 months and older, all other NSAIDs are not suitable for children and adolescents under the age of 18. And this is a very important point. You should only use NSAIDs with the exception of proofing in children 18 years and above. Now, when you take narcotics, whether it's narcotic or narcotic combinations, it's also important to know that narcotics have been associated with some risks, such as respiratory depression or CNS depression. Now, specific CNS depression that is most dangerous is respiratory depression or arrest. This actually is responsible for deaths, for example, that are seen with narcotic analgesics. They also have the potential of being addictive. So they should not be used for, usually for long terms, so that we can prevent the addiction. Their use, on the other hand, can result in tolerance, where a patient will need an increased dose to be able to get the effect that we are looking for. All right. So that brings us to the end of our study for today. I'd like to thank you all very much for your time. And please subscribe to the channel and like the page. Thank you very much. God bless us all. We will meet again. Have a wonderful evening.